afternoon everyone. Today I am going to present on a topic masquerading in plain sight pigmented corneal ulcer mimicking foreign body. A 55-year-old male presented with complaint of left eye pain, watering and redness and diminution of vision for past 1 week, which was sudden onset, gradually progressive. There was no history of ocular trauma or surgery as reported by the patient. Patient is a known case of type 2 diabetes mellitus from past 5 years. There was a history of left-sided 7th nerve palsy 2 months back, for which he didn't took any treatment. There was no history of headache, nausea, vomiting or seizures. Patient took a local consultation for ocular symptoms and was diagnosed as left eye perforated corneal ulcer with iris prolapse and was referred to higher center. On ocular examination, BCA was 612 in right eye. It was hand movement close to face with PR accurate in left eye. DTN was within normal limit in both the eyes. Anterior segment was within normal limit in right eye, and corneal sensations were reduced in both the eyes. On examination, there was a lag of around 5 mm was noted, along with upper lid and lower lid edema. On slit lamp biomicroscopy, a central elevated pigmented lesion with an epithelial defect of almost around 3 into 3 mm, and the ulcer was dry looking with feathery margins, and a 1.5 mm hypopyon was noted. After making the slit, AC was well formed, iris was round and in position, so there was no perforation at all. Lens was NS nucleus corrosive grade 1 in right eye. It could not be assessed in left eye. Posterior segment of right eye showed mild NPDR, and left eye the glow was faint, so we underwent an B scan which showed anechoic vitreous cavity with retina on. So we made a provisional diagnosis of left eye infective keratitis. It was likely to be fungal with a central pigmented lesion with 7th nerve palsy and diabetes mellitus. What next? Then we decided to scrape off the lesion and send it for corneal scrapings. And to our surprise, the entire pigmented lesion was removed in toto, and KOH mount was showed pigmented hyphae along with conidia, which was lunate, brown colored with septate, and the culture showed curvularia lunata. We underwent all the systemic tests of the patient, but they were absolutely within normal limit. So final diagnosis, we made it of left eye fungal keratitis due to curvularia lunata with 7th nerve palsy and diabetes mellitus. We started the patient on eye drop netamycin 5% hourly along with voriconazole 1% hourly, and we also advised the patient to tape the lid at night because there was a lag of around 5 mm. On follow-up, the hypopyon was resolved, ulcer started to heal with pigmentation. Unfortunately, patient was lost to follow-up. That's the picture after 2 weeks, and after that we couldn't trace the patient. So we reviewed the literature and we found a case series on curvularia keratitis, and it showed that the incidence of fungal keratitis is almost around 10.3 per 10,000 of population, and out of fungal keratitis, curvularia is around 3.7, and out of that our patient presented with a pigmentation which is around 25% of all the curvularia cases. So it's some kind of rare condition. So yes, learning points from this case: basically edematous fungi can rarely present with an elevated pigmented lesion which can be mistaken for prolapsed iris. Detailed ocular examination is important to arrive at correct diagnosis. Corneal debridement in fungal keratitis helps in reducing the organism load and improve drug penetration. As diabetes and 7th nerve palsy were 2 important risk factors in our patients, systemic management should be done simultaneously. Thank you.
Yeah, thank you, Dr. Lakshay, for excellent presentation and giving us an idea about the risk factors also, diabetes. And I would like to ask that what you did for that after healing of the ulcer. Did we do anything for the 7th nerve palsy?
Sir, actually we were planning because we were feeling that the patient is a non-compliant one because he was having ulcer from past 1 month and he didn't took any treatment. So in the beginning we gave him lid patching only because we are not sure if he'll do lateral tarsorrhaphy, whether he'll put the drops or not. So we advise the patient to continue the treatment and come after healing, then we'll do the lateral tarsorrhaphy or something like that, but the patient was lost to follow.
Okay. So we need to take care of the risk factors.
Yes,
and thank you so much.
Thank you, sir.